My name is Dr. Bulent Arslan. I practice at Rush University Medical Center in Chicago, Illinois. This is a rapidly growing area in interventional radiology. I remember 20 years ago, very few thrombectomy devices were available, and they could only take very small amount of clot. Over the years, this has changed. A lot of new devices are coming out with significantly higher ability to remove larger amount of clots. The clot retriever and the aspiration catheter combination allows us to move relatively older age clots, which is usually the problem. As you know, the clot, after it's formed, it gets older. We call it acute in the first 2 weeks and subacute after that 2 to 6 weeks, and becomes chronic after that. So the more towards the chronic, the harder to deal with this clot. But when they come into like a harder to remove stage, then you need not just aspiration, but clot retriever option. And then the Laguna system has a very robust one. It's the way that it's designed, self-expanding. It penetrates into the clot and captures the clot with a good force, and with the aid of the aspiration catheter allows us to achieve relatively better outcomes. It's a very wide spectrum of patients. Some patients are not symptomatic at all, and then their clot may be very old. So if you're not symptomatic, you have a very old clot, you leave those patients alone. Acute clot with more symptoms, easy to treat, and you're going to kind of relieve the symptoms a lot easily. And there's a whole spectrum of gray in between those two. So each patient we evaluate one by one. Most of the time these patients have leg swelling, pain, they cannot ambulate. There's like a lot of things that limit their lives, so that obviously in those cases you want to treat those patients in an efficient manner. And also you need to combine that with the risk of the procedure in general. If you go through the lysis method, then you have, even though it may be appropriate for some patients, then you have the risk of having a bleed, others. And in those cases, usually if somebody is older, I try to stay away from that. And in younger patient, they may tolerate a lot, but you have a younger patient, you also want to kind of treat them sooner than later too. So it's a balance between the procedural risk, which has been going down and becoming more efficient, versus the patient's inherent own risk for the procedure. This is the newest available system that we have. Although it has similar properties to a couple other existing devices, it also has very unique features, especially the clot retriever component of this device. In patients that, my vision for now to use this device pretty much in cases that are subacute clot, large amount of clot that needs to be removed relatively short period of time. That's where I want to use this system. In the iliocable system, etc., pretty much like the whole IVC can be cleaned up with this device. In addition, because the size has a significant variability from 12 to 24, it can also be used in the femoral segments as well safely without having to go out to the larger sizes. So we can treat pretty much all the clot from heart down to the popliteal level with this device with the available options. Stroke is not something that I do, but I'm very familiar with how the stroke therapy has developed, because in the early days as IRs we were kind of involved a little bit. And I think the advancements in the stroke therapy had a significant impact in the peripheral venous thrombectomy, because the concept came from there, retrieving the clot with the stent retriever, essentially, these are just now larger size options. And suction, same thing, you know, in the brain, you use like smaller 6 French, 7 French catheters. Now we're using 24 French in the periphery, but the concept is very similar. So peripheral venous thrombectomy is essentially, in my mind, an extension and different application of the initial stroke therapy options.